Buddy, I was looking forward to spend a day in Paris, but unfortunately the trains were on strike once more, and therefore I'm joining now online. And the next 30 minutes is about the metabolic effects of vaso-active drugs, and I will focus actually on the immune modulation effects, mainly of norepinephrine. So to start with physiology, it's good to know that septic shock is an extreme physiological stress to the body. It's a hyperadrenergic state. There's a lot of catecholamine release, and this is done, of course, to fight the shock. But at the same time, we know that persistent and high release of catecholamines has negative effects on the heart, on the gut. It induces insulin resistance, etc. So it's also a negative effect. This is an observational study showing the concentrations in blood of different vasoactive hormones, and as you can see, they are all elevated above the reference value that you would see here in the light blue bars. And those patients that eventually will survive, they show a decrease of all these hormones from the very beginning onwards. And those patients that eventually die, they die despite further increasing or remaining very high levels of these stress hormones. And this is the case for epinephrine and also for norepinephrine. So indicating that indeed, if it's too high for too long, this might be not beneficial for the patients. At the same time, norepinephrine is, of course, the cornerstone of intensive care medicine. We use a lot of norepinephrine. And so in this talk, I will give you an overview of the immune modulating effects of this catecholamine, and I shall also share with you some horrifying new data. So if we talk about catecholamines, we will, of course, focus on beta and alpha receptor function. And of course, we know there is positive effects on the heart, there is vasopressor effects on the vessel, but there are also many other effects on other organs that you might not be aware of. Even ejaculation in men is mediated by the beta receptor. But also on the immune system, there are huge effects, and this is actually depending on what receptor is being activated. So the beta receptor is mainly related to a reduced inflammatory response, so attenuation of the immune response, while stimulation of the alpha receptor is related to a more pronounced inflammatory response. So the opposite effect of the beta and the alpha receptor. So overall, the ideas are that indeed norepinephrine, whilst mainly acting on alpha receptors to induce vasoconstriction, it does have effects on the beta receptor as well, and thereby reduces or attenuates the immune response in several settings. Indeed, this was shown a long time ago already by my fellow Dutchman, Tom van der Pol from Amsterdam, and he gave endotoxin to healthy volunteers. And he showed that if you would give endotoxin to these volunteers on the control situation, there's a pretty much increase in TNF-alpha in this case. But if you do it at the same time, and there's a very low infusion rate of epinephrine, a very low rate because of the cardiovascular effects, the immune response is severely blunted. So there's indeed immune suppression by adrenaline. And this was also shown in vitro. Again, huge amount of suppression if adrenaline is present. And if you actually do the same experiment in the presence of a beta blocker, you can completely restore that immune response. While if you do the same in the presence of an alpha blocker, there is no modulation. So this again shows it's mediated by the beta receptor. But of course, adrenaline, epinephrine, is a catecholamine that mainly acts on that beta receptor. So what about norepinephrine? Would that be less? Well, actually, it shows that norepinephrine has the same extent of this immune suppressing effects, as you can see here, compared to epinephrine. And so these effects are still present. Well, why would that matter in real life? Well, we know now that in patients with septic shock, many patients die because of the primary infection cannot be controlled, or they die later on because of secondary opportunistic infections. So these patients are immune suppressed and they die from that problem. And if we then would have further suppression of the immune system by norepinephrine because they are in shock, this will not help these patients. So far there was only in vitro data available. And related to the clinical consequences, indeed, it was shown in observational studies that if you look at quartiles of how high blood pressure is and quartiles of how much of a vasopressor you need to achieve that, so this is the vasopressor load, you can see that indeed a little bit higher or lower blood pressure did not have any influence on the mortality in these patients. However, if you need more vasopressor load in these patients, blood pressure goes, mortality goes up tremendously. So the conclusion of this observational trial was if you elevate blood pressure to above 70 millimeters of mercury, and you need a lot more vasopressor for that, it might actually increase mortality because of this association. And another very interesting study published years ago, already 10 years ago now, was a study that actually used a beta blocker, esmolol, in patients still in septic shock. So these patients were still on norepinephrine. They had a high heart rate for a couple of days, and then they were randomized to receive the beta blocker or control. And of course, the study focused on heart rate and cardiac workload and how much oxygen was consumed by the heart, with the idea that if you would lower the heart rate, you might improve the outcome of these patients. And indeed it did. There was a huge mortality rate in the patients in the control group. And this was mainly likely related to the very severe subgroup of septic shock patients that remained a high heart rate over time. But the patients treated with esmolol had a much lower and significantly lower mortality rate. And the authors rightfully discuss in their article that this might be related indeed to oxygen consumption and lowering heart rate, but it might also be related to other effects of the beta blocker. For example, the beta blocker might restore immunity, as I told you from the in vitro studies. So sepsis is a dysregulated host response. There are some patients that might indeed suffer from hyperinflammation, and as a consequence, they may have collateral damage to organs, etc. But there are also patients that mainly suffer from suppressed immunity. And so these patients have an insufficient host defense, and they might have reactivation of latent viruses, secondary infections, etc., and they die later on from that. So the dysregulated part of it is really relevant. So we were interested if this could be an unfavorable effect of norepinephrine because all these patients actually received that. And currently there was no human in vivo data. So there are, of course, alternatives. There are specific alpha agonists like phenylephrine, or vasopressin was one that was used at that moment in time. No data on immune responses from these compounds. So we did in vitro studies, animal studies, and a human study. So first to show you that one of the pro-inflammatory cytokines, indeed, if you use one of these vasopressors, you can see that norepinephrine shows a huge decrease in the release of this pro-inflammatory cytokine, but actually also phenylephrine does the same, while vasopressin has no effect on the immunity of the release of pro-inflammation of these cytokines. And we found similar things with other cytokines, except the opposite was ongoing for the anti-inflammatory IL-10. There it was that norepinephrine induced an increased release of this anti-inflammatory cytokine. The same for the alpha agonist, and again, no effect of vasopressin. We used also different blockers of these receptors, and you can see here again, there is a reduction in the release of the cytokines that you can restore if you add a beta blocker, while an alpha, specific alpha 1 or a specific alpha 2 blocker does not bring the response back. And this is the same for the pro-inflammatory as well as the anti-inflammatory effects. So again, this is mediated by the beta receptor. Then we went to animal experiments. And so we have a mouse model, and I will explain it in a second. And we can actually infuse endotoxin, lipopolysaccharide, to these mice, and then sacrifice them and look at the samples. We implant in these mice a little like a rucksack. And this actually is with a semi-permeable membrane. And we put in one of the vasopressors in that capsule, and by connecting it to the intravascular space, this would very slowly and steadily release the vasopressor that was actually used. And so in this way, you have free moving mice that you can treat with these different vasopressors. Again, what we found was if we infuse LPS and the toxin in these mice in vivo, and we give them different doses of norepinephrine, there is a reduction of the release of pro-inflammatory cytokines, while the anti-inflammatory cytokine IL-10 is more released. So there is a huge shift from pro-inflammation to an anti-inflammatory response. And we did the same with phenylephrine and also with vasopressin. And again, let me focus on vasopressin. You can see that the immune modulating effects are not there. There's no reduction in pro-inflammation, and there is no induction of anti-inflammation by vasopressin. So noradrenaline is actually also dysregulating the immune response in both in vitro and in vitro in mice. So next, what we did was using a CLP model to look what will actually happen during real infection with live bacteria. And we looked at the dissemination of these bacteria in different organs. And again, we found that indeed, this suppression of the immunity by norepinephrine leads to more pronounced, as you can see here, dissemination of bacteria to different organs. So in spleen, liver, and blood, there was more pronounced amount of bacteria in those animals that were treated with norepinephrine, while this was not the case for vasopressin again. What about humans in vivo? So that's the last part of this talk. We have a model in our institute in which we can actually infuse endotoxin to healthy volunteers. So we did this study of 40 volunteers. They come to our medium care unit. We line them up and we give them endotoxin. And then for 4 hours, we could also give them a very, very low dose of norepinephrine because of the hemodynamic effects. Same for the alpha agonist and same for vasopressin. Well, vasopressin actually, if you're not in shock, it's not really increasing your blood pressure. So we use the normal dose that we use in the clinic as well. We infused that for 4 hours and we measured multiple times lab samples for cytokine release. So this here you see one of the brave volunteers. They have an arterial line for blood sampling. They have a venous line for the administration of the endotoxin. And so this is at the start of the experiment. He looks pretty happy, but then after a couple of hours, if you have received the endotoxin, you feel sick, you have a fever, and we can take the blood samples to see what happens to cytokines. So again, on the left, pro-inflammatory cytokine IP10, and on the right, the anti-inflammatory IL-10. And as you can see, there's a huge release, very high concentrations of these cytokines. In the placebo group and in the vasopressin group, a similar response, while in the group that was treated as well with noradrenaline or phenylephrine, there was a decrease of release of the pro-inflammatory cytokine, while there was an augmented increase of the IL-10. So again, the similar response as in our in vitro experiments and in the animal studies, there is a huge shift, suppression of the pro-inflammation and actually an increase of the anti-inflammatory response by noradrenaline. We looked at all these different cytokines, and as you can see, indeed, there's a huge increase of pro-inflammation, and the effects of norepinephrine is it's actually inducing a reduction of all the pro-inflammatory cytokine and a more pronounced increase of IL-10. So then we went back to the real septic shock patients, and we had a database and a biobank of 129 patients that were admitted with septic shock, and we were able to sample blood within the first 24 hours after the start of norepinephrine infusion. We went back to the medical records of these patients and found that 66 of the 129 actually used a beta blocker pre-existently. So they had that for their blood pressure or cardiac situation. And so when they were at home prior to the septic shock, they used a beta blocker. And we looked at the samples and we calculated again the pro-anti-inflammatory ratio. And again, we found that there's more pronounced pro-inflammation in the patients that used a beta blocker. So this is similar to the in vitro experiments that if you give norepinephrine in the presence of a beta blocker, you can actually repair that suppression effect of norepinephrine. And we could even find a correlation with the norepinephrine infusion rate. So the higher the amount of norepinephrine infused was, the more pronounced the inhibition of pro-inflammation and augmentation of IL-10 was. So that ratio went down related to the infusion rate. So the conclusions and the consequences are that indeed there is effects of adrenoreceptor agonism on the immune system, mainly mediated by the beta receptor, induction of IL-10 and reduction of the pro-inflammatory response. And we think that is relevant because it's becoming more and more clear that patients with sepsis, they suffer from a paralyzed immune system and they have more likely opportunistic infections and have a higher mortality later on. This is partly related to sepsis itself, maybe to even bigger extent to the disease severity, but these are non-modifiable factors. But also norepinephrine might actually contribute to this immune suppression. And this, of course, is a modifiable factor because you can choose other vasopressors as well. So there are huge gaps of knowledge to find out how this exactly works, how the et cetera, but this is something that is of clinical relevance. Are there alternatives? Yes, I think so, and especially in the last couple of years. For example, angiotensin II. You know, this ATOS 3 study published in the New England, a small study with only 72 and 88 patients in the follow-up. And what they showed in that study was that indeed, if you give angiotensin II in patients with vasodilatory shock, angiotensin II is able to increase blood pressure, and then after 3 hours, the dose of angiotensin II infusion was reduced to the blood pressure that they were aiming for, compared to placebo. So it works as a vasopressor. And what is interesting, if you give angiotensin II, indeed, you need less norepinephrine. So there is a faster reduction of the infusion rate of norepinephrine, especially. And very cleverly, the authors looked at the change in cardiovascular SOFA score, and this was indeed in the angiotensin II group, more pronounced the decrease compared to the placebo group. This is logical because the cardiovascular SOFA score is existing of the amount of norepinephrine that's being infused, and you need less. There's no angiotensin II infusion rate that is used for the cardiovascular SOFA score. So you are replacing it with angiotensin II, and then you will find a decrease of this SOFA score. It does not mean that your hemodynamic instability is less pronounced because you just replace it by another score, by another vasopressor that is not in the score at this moment. There were no signals that there were more pronounced adverse events or any serious issues And also the study was, of course, underpowered to show any clinical benefit. But if anything, you need less norepinephrine if you use angiotensin II, and maybe the all-cause mortality might be a bit lower, but this was far from statistical significance, which is not a surprise. So my take-home message is that angiotensin II can increase blood pressure in patients with vasodilatory shock. And as a consequence, you need less of norepinephrine. So the infusion rate of norepinephrine can be decreased, and it appears to be safe. Now, very interesting, based on this study, they did a post hoc study with the samples that they obtained. In patients with sepsis, there is endothelial injury, and the ACE, the angiotensin II converting enzyme, is not working very well. So as a consequence, you have less angiotensin II, and by feedback mechanism, renin will go up, trying to produce more angiotensin II. Well, what they did, interestingly enough, is look at the samples from the ATOS-3 trial and measure renin activity and see if this would be related to the outcome and treatment with angiotensin II. What they found indeed was that in patients that received angiotensin II, renin went down, significantly so, while it stayed the same in the placebo group. So if you give angiotensin II, the feedback mechanism makes that renin goes down overall because there is enough angiotensin going around. So does this relate to maybe clinical endpoints? So they produced Kaplan-Meier curves according to the renin concentration. And in the patients that actually had renin concentrations below the median, so half of the patients, there was no survival benefit of angiotensin II infusion. However, in the patients with a renin concentration above the median, so these are the ones that have likely not functioning well ACE enzyme and therefore less endogenous angiotensin II, actually, if you give angiotensin to these patients, there is a survival benefit. And this, of course, is really interesting, even if it's a post hoc analysis, and we have to be careful, but it sounds logical. If renin is high, this indicates that your angiotensin converting enzyme is not working well, and less endogenous angiotensin II is produced. And especially these patients seem to benefit if you infuse angiotensin II. So what should we do in the future? This is a very nice commentary from the investigators of the ATOS-3 trial. And what they are proposing is maybe we should give norepinephrine as well as angiotensin II, as well as vasopressin, and then try to lower the vasopressors one by one. And if there's no real decrease of blood pressure, then you did not need that vasopressor. But if there is a decrease, then you have to use that vasopressor again, because it seems to work more in that specific patient. However, the most important question, I think, is indeed, is it the case that if your blood pressure response is more pronounced to a specific vasopressor, does this relate to a better clinical outcome? We don't know that for now. So my final conclusions are: norepinephrine suppresses the immune system big time. There's a huge suppression of the use of norepinephrine, as we discussed. Disease severity is the main driver of immunoparalysis. Disease severity relates to the amount of norepinephrine that you use. So maybe norepinephrine could be the main driver of this suppression of the immune system, and this may have important clinical consequences. And beta blockade therapy might actually counter these unfavorable effects on the immunity system of norepinephrine. So I want to thank all my co-workers who did the work. This is Roel Stolk, who is the PhD study who actually performed all the experiments that I showed you. Jelle is our analyst that measured all the cytokines, and Matthijs was also a co-supervisor during this project. And with that, I thank you for your kind attention, and I'm happy to take any questions.